right, well, thanks very much, John. Thanks as well for inviting me to take part. So my goals are twofold. One is to convince you that we should no longer pursue watch and wait in low tumor burden follicular. My second goal is to do it convincingly enough that John will give up and he'll just say, okay, we're done, we're closing shop for the day. So we'll try to watch and worry no more. So these are my disclosures. So here's some considerations to keep in mind when you are seeing a patient with low tumor burden follicular, and that is, so they're asymptomatic. I'll define low tumor burden in a second. Do you need to treat them, or can we follow what's been an accepted and traditional approach, which is just to follow them until they have symptomatic or overt disease progression? We know, however, that Rituximab as a single agent can give very high responses in the setting of low tumor burden. And in some of these people, and this is a point that you don't want to forget, some of these individuals can have very durable responses going out to 5 years and more after just 4 doses of Rituximab. We have the opportunity to delay a time to cytotoxic therapy. We may be able to bridge them for a number of years with pretty non-toxic treatment to newer non-chemotherapy-based approaches that may give them a very good quality of life and good survival. Potentially less imaging, and we can avoid the, as I said, the watch and worry. So how do we define low tumor burden in follicular lymphoma? So the GELF criteria are as follows, and this has been pretty consistently the standard for assessing this. That is that they have no systemic or B symptoms, that they have non-bulky disease, so no single mass that's more than 7 centimeters, 3 or fewer nodal areas that are more than 3 centimeters, so no splenomegaly, no cytopenias, no effusions, risk of organ compression. So that's the subset of follicular patients we're talking about. There was some early data looking at, if I can find the pointer, I don't see it, there it is, single agent Rituximab in a very early trial that was reported here was active and well tolerated. And so the question that Brad Call wanted to ask when he designed the RESORT trial that I'll go through with you in a few minutes, could Rituximab provide a low-risk treatment and delay the time to first chemotherapy? So here's an early study from John Hainsworth, just 45 patients. These were previously treated, and they looked at just giving Rituximab versus giving Rituximab maintenance, which in this study was done as 4 doses every 6 months for a couple of years. And you could see that there was improved PFS with maintenance, but if you look at sort of Rituximab benefit, there was really no difference. Because you could retreat with Rituximab if need be. So this is an important study that was published by Ardeshina in Lancet Oncology a couple of years ago from the UK. So stage 2 to 4, no symptoms, no prior therapy, and they compared 3 arms, watch and wait versus weekly Rituximab without maintenance after 4 doses. This arm closed early because of a study that came out suggesting a benefit for maintenance, or 4 doses and then 1 dose every 2 months for 2 years. Primary endpoints, time to next treatment and quality of life, and they defined the reasons that would warrant going on to some non-Rituximab-based therapy. So here's what they found. You can see that for patients with watch and wait, that's what it sort of looks like if you're low tumor burden, essentially, and you don't get treated, is that by about 3 years, half the patients have gone on to some kind of therapy. Here in the red is time to start of new treatment if you got maintenance Rituximab, and here it is for that subset. It was a smaller number because that arm closed early, but you can see that even with just 4 doses of Rituximab, they did pretty well. Here's the PFS, but remember, sometimes when you progress, it's low volume disease, asymptomatic, you don't have to treat. There was no difference in time to histologic transformation or survival. Now here, if we just look, actually this should be rituximab followed by maintenance versus watch and wait. It gives you a little clearer view of the difference between those. Now, this is a study I mentioned that Brad designed and led through the ECOG and intergroup process. And it was published in JCO back in 2014. So here's the enrollment. There was a sort of an exploratory analysis of non-follicular indolent non-Hodgkin lymphomas that were also low tumor burden by the same criteria. But we'll focus on the follicular patients here. And there were 109 who did not respond sufficiently to the rituximab and came off study. Those who had at least a partial response or a complete response to the 4 doses were then randomized to rituximab retreatment, which meant that you got 4 doses of rituximab again when the disease reappeared, or they got scheduled rituximab, which was maintenance, and that was 1 dose every 3 months indefinitely until they failed treatment or came off study for toxicity or some other reason. So it closed back in 2008. The non-follicular patients were just reported in the British Journal of Hematology. So here are the ones with follicular. So 7 out of 10 had at least a PR to weekly times 4 rituximab. Only 12% complete remissions, but that's biased on the low side because many of the patients did not have a required bone marrow to confirm CR, so that they had to be called PRs. So 130 to 140 assigned to one of those treatment arms. Baseline characteristics were very similar. I won't go through those. And here we are for treatment failure-free survival. So this means they failed rituximab, meaning they progressed within 6 months of a dose or treatment of Ritux. And you can see that they look very similar, meaning that the retreatment patients could do as well as the maintenance patients when we treated them. Although, if you look at when they got a cytotoxic regimen, it had a favor. It was in favor of getting maintenance therapy. So if you just got retreated, you were more likely to come to cytotoxic therapy sooner. For the ones who got retreated, you can see that the first response, again, going out to 5 years, there were patients still in remission there and beyond. For those who got retreated, the durations of response were shorter. Overall survival between the 2 arms did not differ. So one of the other questions is, well, is there a psychological benefit to being on maintenance as opposed to sort of waiting for the shoe to drop so you have to go back on treatment? Your disease has recurred as opposed to your disease staying in remission. So a variety of tools were used. This was for the follicular patients now reported by Dr. Wagner in JCO last year. And basically there was no clear benefit for retreatment or that retreatment of progression was associated with worse anxiety among these patients. And there were some, I won't go through the details of this, there was some difference for patients who had this so-called avoidant coping approach. They did worse early, but it leveled out after time. So basically not a difference in quality of life that would make an argument. So, conclusions from this study: Ritux retreatment was as effective as maintenance Ritux for time to treatment failure. Maintenance Ritux was superior for time to cytotoxic therapy, but those patients received 3.5 times more rituximab over the course of their treatment than those who just got retreated. So almost 16 doses versus 4. No benefit in quality of life, and there was no difference in number of patients who developed transformed lymphoma. So maintenance didn't suppress that evolution. So 86% of people were chemotherapy-free at 3 years. So given these lacks of differences, I think you can make a strong argument that rituximab retreatment is the strategy if you're going to treat low tumor burden follicular lymphoma. So 4 doses of rituximab, no maintenance, and follow those people and retreat with rituximab unless they have a clinical indication for a cytotoxic-based regimen. So based on this, both the Ardeshna data but also the resort data, rituximab weekly times 4 should be the standard of care, in my view, for low tumor burden follicular. Steve Ansel, in his editorial that went with the Ardeshna paper, made this quote: "Watch and wait is the same as watch and worry." There's an opportunity, again, the point I made early is that a number of these patients with low tumor burden after 4 doses of rituximab will still be in remission 3-5 years and beyond. And so I think you're doing them a favor by giving them the maximum benefit of an immunotherapy in the low tumor burden state. And I think we also have the opportunity to build on this sort of immunotherapy approach using other agents. So maybe one of the newer anti-CD20s with or without one of the pathway inhibitors that you've heard about in the previous talk. So I think we've got some real opportunities to try to get people into a deep and durable remission and defer the risk of them needing cytotoxic therapy or having additional difficulties from their disease for a very long period of time. John, I'll stop there.